Welcome. NSG 525, Study Section 3, Crash Injury. Introduction. In the previous study section, we explored procedures for cardiopulmonary condition. In this section, we will discuss crash injury and how to manage patients with crash injuries as a nurse. Learning outcomes. When you have studied this section, you should be able to discuss incidence and prevalence of crash injuries, identify causes of severe crash injuries, point out damages caused by crash injuries, present pathophysiology of crash injuries, highlight signs and symptoms of crash injuries, conduct diagnosis and treatment of crash injuries, manage patients with crash injuries, describe complications of severe crash injury. Incidence and prevalence of crash injuries. Crash injury is an uncommon injury and the overall incidence is 0.1 per 10,000 individuals. Crash injuries may result in permanent disability or death. Therefore, early recognition and aggressive treatment are necessary to improve outcomes. Victims of natural disasters, include earthquakes, are reported as having up to 20% incidence of crash injuries, as do 40% of those surviving to be extricated from structures that collapse in both natural and man-made disasters. Crash injuries may also be caused by more common events, including vehicular crashes, industrial mining mishaps, and farming incidents, where extremities become pined in moving machines. Mortality from crash injury is estimated to be 5%, but varies with cause. Causes of severe crash injury. Crowds. Badly managed events can result in crowds of people causing crash injuries to one another which trying to exist or leave an event, for example, or reach another part of an enclosed space. Fingers trapped indoors. Door frames are renowned for causing crash injuries to fingers, particularly if they are heavy, solid doors or those which are not fitted with slowing machine or finger guards. Those most at risk are children who will not be aware of dangers of a door frame. Therefore, particular care should be taken to make sure that doors in nurseries and schools are fitted with safety devices to try and prevent injuries of this nature. Forklift trucks. Forklift trucks are very dangerous pieces of equipment and can cause very serious and sometimes fatal injuries through crushing people. The injured person could be a worker in an area close to the forklift truck, the person operating the forklift truck, or a member of the public. The forklift truck will either pin the person up against another object, such as a wall, or topple over onto a person crushing them. Forklifts can run over and crush the feet of people using gangways where there is insufficient separation between pedestrians and vehicles, or where doorways lead directly into the workspace without barriers being positioned to afford protection. Forklift trucks can collide with goods or equipment such as lockers or racks, causing them to topple and in turn crush people nearby. Heavy objects falling. Crash injuries are commonplace when someone has a heavy object fall onto them. This could be something from a fairly low height, such as the person dropping a heavy object onto their foot, or could be an object from a height such as a load being dropped from a crane, for example. Personal protective equipment can protect workers to some degree from this type of injury, such as steel-toe capped boots. Livestock. Victims of attack by livestock often suffer terrible crush injuries due to the sheer size and weight of the animals involved. Machinery. Machinery in the workplace can cause terrible crush injuries, mainly to the fingers or hands of workers who are operating the machines or trying to free blockages. Machines without guides are a big risk, as those who are not maintained properly or had been modified unprofessionally. Workers operating machinery should always be taken provided with thorough training. Road accidents. Road accidents frequently cause crush injuries to those involved, whether they are pedestrians, cyclists, motorcyclists, or other road users. Crush injuries can occur when a driver or passenger becomes trapped inside their own car as the metal body of the car is pushed inward due to a collision. Crush injuries frequently affect motorcyclists who have their legs strapped between the motorcycle and another vehicle when a collision occurs. Crush injuries can also affect pedestrians who become trapped between a vehicle and another object such as a wall. Disasters. This could be natural, e.g. earthquakes, or man-made, e.g. terrorist bombing. Crush injuries most commonly are the result of an accident caused by pressure of entrapment in equipment or machinery. A fall, an automobile versus pedestrian accident, industrial or transportation accident, natural disasters such as earthquakes and landslide. Man-made accidents such as building collapses or acts of wars and terrorism can also result in multiple cases of crush injury. Damages caused by crush injuries. A crush injury can cause both internal and external injuries. Victims of crush injuries commonly suffer from fatalities. Unfortunately, due to the severity of some crush injuries, the victims do not survive. Fractured bones. Bones fractured by a crush injury tend not to be wholly broken but smashed into many different pieces. This type of fracture is called a comminuted fracture. Broken bones can lead to more serious internal injuries if they penetrate organs inside the body or damage major blood vessels or nerves. Compound fractures can occur when a crush injury causes a bone to fracture and the jagged end of the bone is forced through the skin. This type of fracture then poses a serious risk of the wound becoming infected. The bone itself can be severely crushed, and achieving bone reunion can be a long and arduous process. Bone necrosis, death of the bone, may then lead to a need to consider excision of the bone or fusion surgery. Head and brain injury. A crush injury could result in brain damage, which can lead to problems with all aspects of life, such as memory and speech, as well as physical ability and risk of epilepsy. Lacerations. Laceration results in bleeding and the risk of scarring and infection. Paralysis. If the spine or spinal cord is crushed, the victim could be left partially or fully paralyzed as a result. Paralysis can also be caused by a brain compartment syndrome. In many cases of crush injuries, compartment syndrome takes place. Compartment syndrome is caused when the nerves and blood vessels are compressed within an enclosed space. This leads to problems with blood flow and can cause muscle and nerve damage. Equally, crush injuries to the chest and stomach or abdomen can cause a traumatic hernia where the intestines are forced through the stomach wall and then can require painful surgery. When the muscles and tissues are deprived of blood for too long after a crush injury accident occurs, there is a strong chance that the nerves will become severely damaged and the victim will experience muscle death. While most common in crush injuries to the legs, compartment syndrome can occur in any part of the body that is crushed and trapped between two objects for too long. When compartment syndrome is setting in, the first sign is extreme pain, followed by the tingling sensation of pins and needles that the limb experiences when it is asleep, and then eventually paralysis of the limb. Once the paralysis has set in, the pulse will be non-existent in the affected limb. A visual sign of compartment syndrome is swollen skin with a shiny appearance. Other signs and symptoms associated with this include the following: severe pain in the involved extremity, pain on passive stretching of the muscles involved, decreased sensation in branches of the involved peripheral nerves, elevated intracompartmental pressures on direct manometry. Pathophysiology of crush injury. In severe crush injury, the initial injury is at the site of the muscle crushed by the mechanical force of an object. The muscle cells dies as a result of the following: first, the force of the crushing object ruptures muscle cells. Second, the direct pressure of the object on the limb causes muscle cells to become ischemic. The combination of mechanical force and ischemia can cause muscle death within an hour. Third, the force of the crush injury compresses large vessels, resulting in the loss of blood supply to muscle tissue. Muscles can normally survive circulatory ischemia for up to 4 hours before the cell death. After 4 hours, the cells begin to die as a result of the circulatory compromise. This means that as the tissue is compressed, it is deprived of blood flow and becomes ischemic, eventually leading to cellular death. The time to injury and cell death varies with the crushing force involved. However, skeletal muscle can often tolerate ischemia for up to 2 hours without permanent injury. In the 2 to 4 hour range, some reversible cell damage occurs, and by 6 hours, irreversible tissue necrosis generally sets in. The damaged muscle tissue produces and releases many toxins that can have detrimental effects on the body. The longer the victim is trapped, the longer the toxins are given to build up distal to the crush site. The crushing force acts as a dam that prevents these toxins from being released into the rest of the body. Once the force is removed, the toxins are allowed to run freely throughout the body, causing a myriad of problems. Along with the release of toxins after extrication, the victim can become severely hypovolemic from the third spacing of fluid, and the rapid swelling of the injured area can cause acute compartment syndrome. Toxins released by damaged muscle tissue and their effects include histamines, vasodilation and bronchoconstriction, lactic acid, metabolic acidosis and cardiac dysmias, nitric oxide, vasodilation which worsen hypovolemic shock. potassium, hyperkalemia, thromboplastin, disseminated intravascular coagulation. In addition to ischemic cell damage, direct injury from the crushing forces causes cell membrane failure and the opening of intracellular sodium and calcium channels. The opening of these channels resulting in the shift of calcium and sodium into hypoxic cells. This damages myofibril proteins and results in both worsened cell membrane dysfunction and release of ATP-inhibiting nucleases. The resultant pressure-induced reduction in aerobic metabolism is further compounded by the ischemia of reduced blood flow. Following extrication, return of circulation to the injured and ischemic area also results in injury, as reperfusion leading to increased neutrophil activity and the release of free radicals. Superoxide, the anion form of oxygen, and the hydrogen peroxide react to form hydroxyl radical, which in a large enough concentration damages cellular molecules and causes a lipid peroxidation. Lipid peroxidation leads to cell membrane destruction and cell lysis. Acute renal failure. A complication is caused by hypoperfusion of the kidneys, which normally receive 25% of cardiac output. These hypoperfusion compounds the toxicity caused by cast formation and mechanical blockage of the nephrons by myoglobin. Myoglobin, an oxygen-binding molecule, contains a heme group and a globin group that dissociates into globin and ferrienates when released into the circulation, especially in an acidic environment such as that of hypoperfusion. Myoglobin and myoglobin breakdown products, particularly in the presence of acidic urine, have a toxic effect on the renal tubules and react with the term phosphoproteins in the renal tubules to form casts, and underscores the importance of early vigorous volume resuscitation to improve urine flow, which dilutes and clears toxin. Another complication of crash injuries is the development of compartment syndrome, which occurs when pressure increases within a fascia encased region, classically a muscle group or the abdomen. The fascia provides a non-expandable space, and as fluid is sequestered, the pressure within the compartment rises. With the rise in pressure, the microvascular circulation is compromised, leading to tissue ischemia. The signs and symptoms of compartment syndrome in an extremity include pain out of proportion to the injury or with passive motion, pallor, paresthesia, pulselessness, and paralysis of the affected extremity. Attempts should be made to intervene before there is a loss of pulses, and omnious find that almost always reflect irreversible tissue necrosis. Compartment syndrome may also occur in the abdomen. To monitor abdominal compartment syndrome, bladder pressure may be obtained through an indwelling urinary catheter. Pressures higher than 25 mmHg often warrant surgical decompression. Signs and symptoms of crush injuries. This depends on the severity of the crush injury. In major crush injury, there is often serious damage below the skin, including tissues, organs, muscles, and bones. A crush injury will often cut off the flow of blood in the damaged appendage, leading to serious muscle and tissue damage, as well as numbness and possible paralysis. There is also a much greater chance for infection in the damaged tissue and muscles. The force of the impact can also cause serious damage to the skin, in some cases completely removing layers and leaving the wound exposed to infection and deformity. Infection can lead to amputation in extreme cases. Some or all of the following may be present. Skin injury may be subtly bruised and discolored, but the skin may remain intact. Swelling, usually a delayed finding and appears rapidly after pressure is relieved. Paralysis may cause crush injury to be mistaken as a spinal cord injury. Paresthesia's numbness may mark the degree of damage. Pain often becomes severe upon release. Pulses, distal pulses may or may not be present. Myglobinuria, the urine may become dark red or brown, indicating the presence of myoglobin. Hyperkalemia, as mentioned earlier, hyperkalemia is often present in a patient with crush injury syndrome. In the absence of laboratory analysis, the degree of hyperkalemia can be estimated crudely from the electrocardiogram. It is almost helpful to compare serial ECG than to look at only one. The classic electrocardiographic changes are as follows. Mild hyperkalemia, moderate hyperkalemia, prolonged PR interval, decreased P wave, amplitude depression or elevation of ST segment, slight widening of the QRS complex. Severe hyperkalemia, further widening of the QRS due to bundle branch or intraventricular blocks, flat and wide P waves, Reckenbeck ventricular ectopics. Life-threatening hypokalemia, loss of P waves, AV blocks, ventricular dysrhythmias, further widening of the QRS complex, eventually forming a sinusoid pattern. Diagnosis. As history, an individual with a crush injury may complain of pain, swelling, bleeding, damaged skin, and numbness or loss of sensation in the affected area. A detailed account of the accident or source of injury is needed if the individual is conscious, or from witness if the individual is unconscious. Physical examination. Examination of the crushed limb or body parts may reveal edema, bleeding, pulse may be difficult to palpate, hematoma, and fracture. The entire body will be examined for signs of multiple injuries, including possible head injury. Vital signs, blood pressure, heart rate, and respiration are closely monitored. Injuries to the chest or abdominal may cause shallow, restricted breathing. Heart arrhythmias may be present. Degree and duration of compression, structure and makeup of the crushing surfaces, and the number of injured extremities determines the severity of rhabdomyolysis. Dangerous signs that could lead to death from severe crush injury are low fluid volume, extreme hypovolemic shock, high blood potassium concentration, hypokalemia, pressure, low blood calcium concentration, hypocalcemia, metabolic acidosis, acute myoglobinuria renal failure, increased intercompartmental pressure, compromised circulation, and compartment syndrome. Laboratory investigation. Urinalysis. A fresh specimen of urine should be checked for the presence of red blood cells. If the urine dipstick test is positive for blood but RBC are present, myoglobinuria should be suspected. Whenever the patient's urine appears to turn dark red or brown, myoglobin is detectable with the same dipstick test that detects hemoglobin, and the urinalysis also may reveal pigmented urinary test. Blood test. Creatine phosphokinase level should be checked, and an increased level of this enzyme is a sensitive indicator of damaged muscle from any cause. Also, serum myoglobin level should be assessed. Normal serum myoglobin concentration is 85 mg per ml or less. If more than 200 gm of muscle are injured, serum myoglobin level increases to greater than 1.5 mg/dl and detectable myoglobinuria results. Test. X-rays in combination with MR and CT scan will be used to identify fractures, electrolytes, and urea in combination with MR, CT scan, and X-ray is necessary to determine evidence of potassium-induced cardiac disturbances and to identify more complex soft tissue injury and internal injuries. Pulse oximetry may be used to monitor tissue oxygenation. Treatment. Pre-hospital treatment of victims suspected of developing crush injury syndrome can be broken down into two parts: the extrication phase and the post-extrication phase. In the first phase, rescuer safety is the first priority. Once that has been established, treatment can begin. Initially, treatment is the same as for any trauma victim. The airways, the priority breathing, and circulation are close behind. Objective of treatment for crush injuries: restore blood volume and flow of blood and oxygen, correct electrolyte and pH imbalances, and maintain renal function. Treatment of crush injuries varies according to the nature of the crush wound, the extent of damage, and the presence of other injuries such as fracture. Treatment for individuals with multiple crush wound consists of early administration of intravenous fluid preferably given at the site where trauma occurred, followed by an osmotic diuretic monitor that prevents reabsorption of water by the kidney. This treatment can prevent shock and arrhythmias. With this regimen, survival of lives and limbs increases substantially, as does prevention of acute myoglobinuric renal failure in individuals suffering from rhabdomyolysis. Ischemia, ischemic injury to nerves and muscles, compartment syndrome, heart and arrhythmia, and cardiac function irregularities may be treated with continuous oxygen at high pressure. Hyperbaric oxygen therapy, fluid and electrolyte replacements may be necessary to correct arrhythmias and rhabdomyolysis. Surgical treatment is often only option. In an acute situation, it may be difficult to decide whether an attempt at a salvage procedure should be made or whether a primary amputation should be performed. In certain situations, such as interruption of blood flow, primary amputation of an extremity may be the treatment of choice. Penetrating artery injury from a concomitant open fracture may require orthopedic and vascular repairs to stabilize the skeletal integrity and restoration of blood circulation. Intravenous fluid. The mainstay of treatment for crush injury syndrome is intravenous fluid. Initially, any pre-existing dehydration of fluid loss should be corrected. The patient's fluid volume status should be corrected to normal, which may require several liters of fluid before any compression is lifted from the patient. Multiple intravenous lines are appropriate because the patient will require large fluid volumes and there is risk of dislodgement during extrication. Intravenous IV fluids containing potassium, if the lactated ringer solution, should be avoided to prevent hyperkalemia. Normal saline is a good initial choice. The amount of fluid to administer is often difficult to predict based on the patient's initial presentation. The usual volume replacement starts with a fluid bolus of at least 1.2 liters for an adult patient and 20 ml/kg for a pediatric patient, given as rapidly as possible. Once the compression is lifted, it is critical to maintain a high urine output. Placement of a Foley catheter will allow more accurate measurements of urine output as well as pH. One formula that can be used to maintain an alkaline urine output of 8 liters per day is the infusion of 12 liters per day of normal saline solution with 50 MEq of sodium bicarbonate per liter of fluid plus 120 grams of mannitol daily to maintain this urine output. Another regimen is 12 liters per day, 500 ml per H of a solution containing sodium 110 mmol per liter, chloride 70 mmol per liter, bicarbonate 40 mmol per liter, and mannitol 10 grams per liter. Sodium bicarbonate. Sodium bicarbonate has several actions that are useful in the patients with crush injury syndrome. It will reverse the pre-existing acidosis that is often present. It is one of the first steps in treating hypokalemia. It will also increase the urine pH, thus decreasing the amount of myoglobin precipitated in the kidney. It is recommended that 50 to 100 MEq of bicarbonate, depending on severity of injury, be given to a victim prior to release from compression. This may be followed by continuous infusions of bicarbonate as described under intravenous fluid. Treatment of hypokalemia. In addition to sodium bicarbonate, other treatments may be needed to reverse hypokalemia depending on the severity of injury, and these include insulin and glucose, calcium intravenously for life-threatening dysemias, beta-2 agonist, albuterol, metoprolol, metoprolol sulfate, alupent, etc. Potassium. Potassium binding resins such as sodium, polystyrene, sulfonates, cryolates. Dialysis, especially in patients with acute renal failure. Alkaline diuresis. The patients with crush injury syndrome should maintain a urine output of at least 300 ml per H with a pH higher than 6.51. This can be achieved with intravenous fluids, mannitol and sodium bicarbonate, 44 to 50 MEq per liter. of extravenous fluid, as described above. Other treatments that have been used are renal dose dopamine at 2 to 5 mg per kg per minute and furosemide at 1 mg per kg. Acetazolamide 250 to 500 mg may be used if the patient becomes too alkalotic. Intravenous mannitol. Intravenous mannitol has several beneficial actions in the victim of crush injury. It protects the kidney from the effects of the rhabdomyolysis, increases extracellular fluid volume, and increases cardiac contractility. In addition, intravenous administration of mannitol for 40 minutes successfully treated compartment syndrome with relief of symptoms and reduction of swelling. Mannitol can be given in dose of 1 gm per kg or added to the patient's intravenous fluid as a continuous infusion. The maximum dose is 200 gm per day. Doses higher than this can cause renal failure. Mannitol should be given only after good urine flow has been established with IV fluid. The prevention of crush syndrome is the primary goal of the treatment of crush injury. Intravenous fluid containing both sodium bicarbonate and mannitol is given to patients to prevent kidney damage and stabilize blood pressure. Wound cure. Wounds should be clean, debrided, and covered with sterile dressings in the usual fashion. Splitting the limb at heart level will help to limit edema and maintain perfusion. Intravenous antibiotics are used frequently. Medications for pain control can be given as appropriate. Tourniquets are controversial and usually not necessary. Pneumatic anti-shock garment. Application of the PASG should be avoided. The use of PASG has been reported to cause compartment syndrome and crush injury syndrome. Hyperbaric oxygen. There are cases of reports of hyperbaric oxygen improving the outcome of victims of crush injury. The use of this modality will be limited in disaster situations because of lack of access to hyperbaric chambers, but oxygen therapy must be provided. Surgical management. Amputation. Amputation in the field should be used only as the last resort. It might be the appropriate rescue strategy for a patient whose life is in immediate danger from another collapse or hazardous materials and who cannot be extricated by any other means. It is a difficult field procedure that greatly increases the patient's risk of infection and bleeding. Surgery may be needed to repair the damage to nerves and bone. To prevent infection, patients may receive antibiotics and a tetanus shot. When a crush wound to a limb is too severe to repair, the usual result is amputation of the crushed limb to prevent gangrene. Recovery after amputation is usually complete. However, death from other complications of rhabdomyolysis is still possible. Crush injuries can be severe and devastating to the individual. Long-term impairments and disability may occur, and disability is sometimes permanent. Fasciotomy. Field fasciotomy is also a controversial procedure which may further expose the patient to the risk of infection and bleeding. It converts a closed injury to an open one, risking infection and sepsis. Several studies indicate a worse outcome in patients who received fasciotomy compared with those who did not. It is felt to be indicated only in a potentially viable extremity that is pulseless due to elevated intracompartmental pressure. Outcome varies with the extent of the crush wound and presence of other injuries. Outcome is excellent for otherwise healthy individuals who do not go into shock with injuries that do not require mechanical ventilation or amputation, and if minor or no surgery is required. Rehabilitation. Crush wounds require a multi-level approach to rehabilitation since they involve damage to the muscle, bone, nerve, and soft tissue. Although usually confined to a general area of the body, crush wounds typically affect multiple body parts and may involve both legs and the pelvis or an arm and the chest. Severe deformity and psychological trauma can result in these types of injuries. In the mildest form, a crush wound may only affect a finger or two and will require only a short rehabilitation period. However, complications from tissue or bone necrosis due to ischemia are always a possibility. For more severe cases, Rehabilitation process is arduous and requires the combined effort of many post-acute healthcare professionals, including physical, occupational, and vocational therapists, as well as psychiatric and/or psychological professionals. Rehabilitation therapy does not begin immediately because of threat of kidney failure or embolism blockage. Kidney failure is of great concern when the crushed wound involves the legs due to necrosis of muscle and increased renal burden. Rehabilitation begins when the individual is out of acute danger and stabilization of fractures has been assessed. One problem with delaying physical therapy is the complications that arise from the use, such as muscle atrophy, decreased joint range of motion, and insufficient circulation of blood through injured areas. The sequelae of these issues could lead to poor recovery outcomes, including amputation. Pain management is also a concern since multiple operations and prolonged recovery may influence an individual's mental status. Psychological support service may help reduce anxiety and ease restlessness. Visualization techniques may help prepare individuals to accept themselves with a possible disability and or deformity. Individuals may remain immobilized for the first 6 weeks post-trauma. A series of reparative surgeries may be needed during this time. Exercise rehabilitation is progressed slowly in all cases. Therapy protocol varies greatly due to the wide range of possible outcomes. The individual may undergo treatment, both upper and lower body simultaneously. All treatments are performed to pain tolerance. It should be noted that amputation of the affected limb may be a treatment necessity during early stages of treatment and rehabilitation. If the limb must be amputated, the individual should begin education on prosthesis. Rehabilitation protocols should be redesigned to teach daily living skills and functioning given to the absence of the limb. If the rehabilitation progresses, the individual advances to exercise that include an active range of motion where the individual moves the remaining parts of the extremity or the entire extremity if amputation has not been performed. Rehabilitative therapies, however, must be based on the extent of injury and current level of function. Another important aspect of rehabilitation is scar tissue care. The individual may use massage techniques to continue to break up scar tissues along the surgery site. The individual may experience extreme sensitivity at the site of surgery. Therefore, it is important to initiate activities that decrease hypersensitivity, desensitization, such as applying various degrees of touch and gentle pressure and exposing the site to different textures and sensations. So after temporarily stabilizing, orthopedic hardware, pins, rod, etc. is removed from the limb. More functional exercises are performed. It may take as long as 2 to 3 months for the individual to attempt actual weight bearing on lower extremities. The individual is taught to use a wheelchair. Other therapy during this time may include participating in an aqua or well pool routine to increase blood flow throughout the body and to increase the range of motion for the hips, legs, and arms. The exercise stimulates normal movements and serves to improve aerobic conditioning. Individuals experiencing an amputated arm use the pool to regain body balance. An occupational therapist may be needed to evaluate the remaining function, particularly for those individuals who have lost a limb. It is critical to properly assess the physical and mental capabilities of the individual to understand vocational constraints. Psychological counseling and also may be needed as the individual faces new physical challenges and permanent care. Nursing management of a patient with severe crush injuries. In nursing management, the airway is the priority. Breathing and circulation are next to it. Establish intravenous IV access, preferable to large bone, 4 gram lines, and replace lost fluid before extricating the victim. Normal saline is a good initial choice for fluid replacement because it does not contain extra electrolytes that can compound any toxins in the body. The nurse performed a thorough history and physical examination. A detailed history should include the mechanism of injury, information about the injury object, and the manner in which the foot and other body parts was affected by the object. The nurse should proceed to evaluate soft tissue injuries, noting all contusions, abrasion, lacerations, and penetration. Other management involves ensuring cardiac monitoring, monitoring of oxygen saturation with pulse oximeter. Patients might need ventilation depending on the condition of the patient. Checking the level of consciousness using the Glasgow Coma scale. Controlling external bleeding with direct pressure or sterile pressure, dressing and elevation of the parts affected. It is important to check capillary refill and distal pulses. Thus simple to check indicate of adequate circulatory status. Check neovascular status distal to injury. Elevate injured limb if possible. Apply aspart to affected areas. Obtain X-ray of the affected parts after stabilizing the patient. Administer tetanus prophylaxis if skin integrity is compromised. Mark location of pulses to facilitate repeat assessment. Splint fracture sites, including joints above and below fracture. Monitor vital signs, level of consciousness, oxygen saturation, neovascular status and pain. Observe the patient and acute renal insufficiency. Administer medications for pain and anxiety as prescribed. Ensure that investigations like electrolyte level, PCV, group and cross-match blood for transfusion. The patient is then transferred to the operating theater for wound debridement and fracture repair. Proper skin preparation is very important, and the aim is to assist in the cleansing and the removal of debris and air, thus reducing the possibility of infection. If the skin has a compartment pressure exceeding 30 mmHg and has findings suggestive of compartment syndrome and normal compartment pressure is 10 mmHg or less, prompt treatment is essential. Management involves surgical intervention. Open the compartment by performing a fasciotomy to compress the compartment and allow for reperfusion of the muscle. The nurse should observe the patient for the following: hypervolemic shock resulting from bleeding, paralysis of any part of the paralysis of any part of the body, erythema and blistering of the skin, damaged body parts, usually an extremity, appearing swelling, pains and hard, renal dysfunction, prolonged hypotension causes kidney damage and acute renal insufficiency. Myoglobinuria secondary to muscle damage can cause acute renal failure. 8. Complications of severe crush injuries. 8. Complications of severe crush injuries. Prolonged severe crush injuries can result in severe systematic manifestation of trauma and ischemia involving soft tissue, skeletal muscle, nerves and vascular tissue. This leads to increased permeability of cell membranes and to the release of potassium, enzymes and myoglobin from within cells. Ischemic renal dysfunction secondary to hypotension and diminished renal perfusion results in acute tubular necrosis, uremia, and sometimes renal failure, which can be fatal. Other possible complications include increased clotting of blood, hypercoagulability that can result in deep vein thrombosis and pulmonary embolism or stroke. Immune suppression that results in infection at the wound site or systematically sepsis, hemorrhagic shock, and lipid embolism that results in reduced levels of blood oxygen, acute hypoxia. Elevated intracompartmental pressure within a closed compartment, acute compartment syndrome, such as a portion of an injured leg or the entire abdomen, is a serious complication of rhabdomyolysis that can lead to severe systemic complications. Hypothetical case: Mr. A, 35 years old man, was rescued from a car that was crushed by a lorry along Lagos-Ibadan road. He was unconscious with marked bruises all over his body, and he had an open wood fracture where he was bleeding, and the wheel steering was directly applied on the chest. He was admitted into the accident and emergency unit of the Lagos State Teaching Hospital. Vital signs on admission were temperature 35.8 degrees Celsius, pulse rate 100 beat/m, respiration 42 centimeter, and blood pressure 90 to 50 mmHg. Nurse's diagnosis of Mr. A. Altered breathing pattern related to the compression of the chest by the wheel steering as evidenced by respiration of 42 C per minute. Ineffective tissue perfusion peripheral related to hemorrhage as evidenced by Park cell volume of 19%. Disturbed sensory perception related to unconsciousness evidenced by Glasgow Coma scale of 5/5. Study section summary. In this study section, severe crush injuries are rare but fatal, but it occurs and an aggressive treatment is of great importance to reduce the mortality and morbidity resulting from it. Severe crushing injuries and life-threatening complications are major causes of death after major disasters like earthquakes. Prompt treatment and close monitoring of the severe complications are of great importance in saving patients' lives. Establishment of a well-equipped frontline ICU close to the epicenter of the earthquake allows for prompt on-the-spot rescue of critical patients with crush injury, greatly decreasing the mortality rate and complications and avoiding amputation. We've come to the end of study section 3. Thank you for listening.